Good morning, everyone. It's a privilege to be a part of EESCON today. And I'm going to start with the first lecture, that endoscopic anatomy of the middle ear. We all know anatomy is usually a very boring topic, but I'll try to make it as good as interesting as possible, because what we have learned during our PG and UG is not the endoscopic anatomy what we see and what we read in the books now. So I'll try to merge the two things so as there is a smooth harmony between what we have learned and what I'm going to tell today. Microsurgery of the middle ear is usually performed, as we all know, and we are all trained with the microscope during the 3 years of our postgraduate training. So little bit different to what we have been doing is, so microsurgery of the middle ear is traditionally performed with a microscope, and we all have been trained under the microscope for the last so many years, that is during our PG training as well as after the post graduation. Uh, what we all know about the microscope is that it gives beautiful magnification, it gives wonderful illumination. But the only problem with the microscope is it gives a straight axis, and whatever is beyond the corners, you are not able to see it unless you move the head of the patient or try to tilt the microscope. So with this, initially about 1.5 decade back, what was started was the use of endoscope as an adjunct. That is, whenever you wanted to see certain spaces in the middle ear which could not be seen without the direct removal of the bone, used to be observed with the help of the endoscope. So exploration of the middle ear spaces can be accomplished with the help of the endoscope. And nowadays, we, other than using the 4 mm wide-angled endoscope, there are also 3 mm wide-angled endoscope, which gives you a better picture of all the spaces of the middle ear. So because of the anatomy, what has been, I would say, revolutionized, the concepts which have been changed by endoscope, there has been more a focus which has been put on the middle ear spaces, the ventilation, which has played a very important role in the success of the middle ear surgery. So endoscope can help in the wide visualization of the spaces. You can see the two pictures. On one side is a microscopic view, which shows the same area, and on the right hand side is the visualization with the, is it seen over there? Yeah. So basically all the structures are being seen more clearly, they are more crispy. And if you want to see a certain area nearer, you can just either use the zooming action of the endoscope or simply take the endoscope nearer to it, so that you don't only get a straight axis vision, but also a wide angle, which will allow you to go around the corners. This is with a 0-degree endoscope, but if you use a 45-degree endoscope or a 70-degree endoscope, you just place it in one side and you'll be able to see everything beyond the corners. And this is very important during tympanoplasty when you want to visualize the ventilation, if it is being blocked by the glue or with the granulations, other than removing a lot of bone, which is usually done with a microscope. So now the UG concepts, I'm just trying to match the two things. So basically what we have studied during the UG and the PG is the middle ear cavity consists of the epitympanum, the mesotympanum, and the hypotympanum. Epitympanum is whatever lies above the level of the mesotympanum, that is in relation to the pars flaccida. Mesotympanum, the tympanic cavity proper, which is the main portion which is situated medial to the tympanic membrane, and the hypotympanum. The mesotympanum, the classical teachings, which has been, that is, the roof is made by the tegment tympani, the floor by the thin plate of bone which separates it from the jugular bulb, and the lateral wall, which is made by the tympanic membrane, which forms the major part of the central portion of the lateral wall. So now mesotympanum, the medial wall, that is, it's the part which separates the middle ear from the inner ear. Then it consists of the promontory. Posterior to that are two important structures, that the subiculum and the ponticulus, what I'm going to talk about much more detail. Ponticulus is nothing but on the medial wall, if you see, there is at times, most of the times, there is a fine, it's a bridge or like a structure which is moving from ponticulus, that is P. If you just see, it consists two structures which are named after P, that is promontory with the pyramid. So it's a structure, it is basically dividing the mesotympanum, the posterior part, into certain structures depending upon the two structures, that is the ponticulus and the subiculum. And between these two regions, there's a space, and then below that and upper that. And subiculum, what I've said, is the ridge of bone which is inferior to the ponticulus, which is formed by the posterior prolongation of the promontory. So now the variations. So whenever it's a, because we know that temporal bone is like a Pandora's box. You do not know what would come. So no middle ear surgery is a classical one, that you would not find exactly the same thing. And there are multiple variations which are seen. And because of these variations, which are depending upon the extent of pneumatization, the anatomy which is there would vary. So in case, if this ponticulus is not just a ridge of bone onto the medial wall of the mesotympanum, and if it is not a straight one, that is not from promontory to the pyramid, and if it is a partitioned one, or if there is an extra one, what would happen? So there would be multiple variations which would be seen. So if it is a straight one, as I've said, that's a classical one which would go from promontory to the pyramid. It's a complete one. In case if it is not a ridge, it's like a bridge and there's pneumatization under it. So one space would communicate with the other space. So basically the space which is between the ponticulus and the subiculum is nothing but the sinus tympani. And the space which lies superior to the ponticulus is the posterior sinus. So if it's a bridged one, that is, if there is a space pneumatization below it, this sinus tympani would communicate with the posterior sinus. So I'm not trying to confuse you all. Basically, all these things have come because chances of cholesteatoma are very much to remain in certain places. So you should use the endoscope to explore this. So if it is communicating, there are high chances that the cholesteatoma would be going to the other spaces. Okay. So as I said, one is incomplete, one is the classical one, and one is the communicating, that it's a bridged one, and there would be spaces which are communicating. So now coming to the retrotympanic space, you can see a diagrammatic representation over here, pyramid, and there are four spaces which are there. So basically, these four spaces are in relation to the facial canal. So whatever spaces, there are two spaces which lie lateral to the facial canal and two which lie medial to the facial canal. So lateral which lie to the facial canal are the facial recess and the lateral tympanic sinus, and medial to the facial canal. So again, depending on the extent of pneumonitis, your facial canal is there, your middle ear is there. The spaces which lie medial to it, lateral to it. Lateral to it would be the facial recess and the lateral tympanic sinus, and the medial to it would be the sinus tympani and the posterior sinus, which I've already described. Okay, so a little bit brushing of what I have said. Sinus tympani is nothing but the space which is enclosed superiorly by the ponticulus, inferiorly by the subiculum. It lies lateral to the posterior semicircular canal and the vestibule. Basically, it's the space between the medial wall and the part of the posterior extension is variable. So just consider the part of the posterior part of the mesotympanum. It's a cavity. This is the medial wall. This is the lateral wall. This is the space. There's a facial canal over that. And the spaces over here, two spaces, sinus tympani between ponticulus and the subiculum inferiorly. Okay. So back again, if there is lot of pneumatization, it wouldn't be a small or a classical sinus tympani. It can be varied. It can pneumatize beyond the facial nerve. If it is pneumatizing beyond the facial nerve, you'd have a very deep sinus tympani. and chances of having cholesteatoma in that part would be high. Okay. So depending on the shapes, it's a classical one where it's located between ponticulus and the subiculum. Confluent type, which I have said, when the ponticulus is bridging. So it would be communicating with the posterior sinus. Partition type, there is additional bone which is developed. So your sinus tympani would be, other than one complete one between ponticulus and subiculum, it would be divided into two. So basically the anatomical variations, the pneumatizations, the extra bone which is grown. And restricted type is when the subiculum is pushed upwards because of the high jugular bulb. So relations of the sinus tympani, again repetition of the previous slide, what I have been repeating over the last few minutes. So superiorly by the ponticulus, inferiorly by the subiculum, laterally by the part of the facial nerve form, which forms the lateral into the opening of the sinus. Circular the nerve. So depth of the sinus tympani. All this is not to complicate the matters, just to tell you that everything, whatever details from what I'm telling, the anatomy has reformed over the last 2 decades, that is 1.5 decades since the advent or the inclusion of endoscopes during the middle ear surgery. So classical one, type 1, it's a small sinus tympani. If the pneumatization goes beyond the facial nerve medially, then it will be type B. And if it is much more pneumatization, it would be type C, that it would go over here. What you can see, classical one, first picture shows the classical one, type A, type. Is the arrow seen over there? Okay. In the second one, it is medial, and over here you can see it goes much posterior to the facial nerve. Okay. Now the epitympanic spaces. So we know that epitympanic spaces, again, this concept has come because of the ventilation pathway. We know that eustachian tube directly ventilates the mesotympanum and the protympanum, but not the epitympanum. So how the epitympanum gets is ventilation. Because if this ventilation is blocked, that's all the reason why you have this ventilation syndrome, you have the glue forming, you have the granulations forming, and a simple innocent looking perforation may not heal in spite of giving everything possible. It would be again giving rise to discharge. So what are the reasons for the discharge when it's an innocent small perforation? There would be something in the epitympanic spaces in the ventilation pathway which is not allowing the air cells, rather the mastoid air cells, to breathe. So this is the concept over here, that the epitympanic spaces, two spaces, anterior epitympanic space and the posterior one. Anterior is smaller, posterior is larger. And the demarcation between the two is a simple one, that's the fog. What we have learned, fog is nothing but the ridge of bone which is between the tegment tympani to the level of the cochleariformis process. So it's a bone which is there. So anterior epitympanic space which is small, posterior which is large. Anterior one is obviously anterior. Posterior one is the one which is having the ossicles, that's the head of the malleus, the incus, and everything posterior to it. So how is this ventilated? So there is what I have been speaking, what I'll be speaking over the next 2 minutes is an epitympanic diaphragm. Little bit to complicate the matters further. So just imagine you have 3 ossicles suspended in the middle ear. Mesotympanum is there. On top of that, the epitympanum. Hypotympanum is a small part which is there, space which is there. So epi, meso, and the hypotympanum. Just imagine there is a partition. Imagine there's a partition between the epitympanum and the mesotympanum. And this partition is having certain spaces. These are the certain spaces which are fixed ones, which are known as the anterior isthmus and the posterior isthmus, and certain which are may or may not be present, like the spaces or the defects in the tensor fold, which is open in 25%. So these are the spaces through which the eustachian tube could ventilate the epitympanum, edetus edentrum, and the mastoid. So if there is a block at this crucial spaces, that's the posterior isthmus and the anterior isthmus, so it wouldn't ventilate the mastoid and the edetus edentrum, and that's the time when you get everything. That's the glue, the granulations, there would be mucosalization, and finally the cholesteatoma. So, little bit details of the epitympanic diaphragm. I'm just trying to simplify the matter, not going much into the complexities. So, the epitympanic diaphragm, what I have said, it consists of the three malleol ligaments, that's the anterior, lateral, and the posterior. The posterior inferior fold, the two membranous folds, that's the tensor fold, and the infusomedullary fold. So basically, simple thing, there is something which is partitioning, and there are gaps between the two. That's why it's ventilating, and these gaps have to be there so as to ventilate the posterior part of the epitympanic. So I've talked about this. So you can see over here. So whatever is put in the pictures and has been, these all are taken from Professor Daniel Marshoni's book on endoscopic ear surgery. So whatever he has tried to put in these pictures, I've tried to simplify in the simple words, that is, eustachian tube would directly ventilate the mesotympanum, and to ventilate the epitympanum, it has to go through two spaces, anterior and posterior isthmus. Not to complicate the matter further, whatever has been described in the books, two simple words. Anterior isthmus, what is it? You have the three ossicles, malleus, incus, and the stapes. Okay, between the handle of the malleus and the incus, that's the long process of the incus. The space which is there, that's the anterior epitympanum, anterior isthmus. Posterior to the incus, the space which is there, that's the posterior isthmus. So it has to be clear. If you read it, technical details, it would take time to decipher the details. So simple words, the space between the malleus and the incus, anterior isthmus, posterior to the long process of the incus, is the posterior isthmus. Anterior to the handle of the malleus is a fold which is orientation is similar to that of the epitympanic diaphragm, that's the tensor fold. I would show it. So we all know about the prosthetic space. Again, its ventilation is dependent upon these isthmuses. So basic certain landmarks which help you in orientation during transcanal endoscopic ear surgery. So sorry, I forgot to tell you one more thing. So why endoscopic anatomy is important basically when you have learned the microscopic anatomy? Because the whole concept of the surgery is different, because when you do a microscopic surgery, you do the post-oral incision, you approach the cavity or the cholesteatoma, mastoidectomy from behind into the middle ear, you do the mastoidectomy, then you come to the middle ear. But in endoscopic ear surgery, your orientation, your approach is absolutely different. You see from what is there in front of you and then you go behind. That is, you given transcanal incision, it can be either a transcanal incision, endoscopic one, or an endoral incision, but it is from inside, you'll go outside. Again, your concept of mastoidectomy would be different. That is not the posterior cortical is not done first and then you don't come in inside. It's basically from inside you go out. So basically this is important so that your orientation is totally different. It's not a complicated one. Basically it's a simple one, but little bit changes, and microscopic and endoscopic, these are not two different things which are there. Basically it's just the approach and the tool which is different. The anatomy would remain similar, only thing the way you look at the structures would be different. Okay. I've told about the tensor fold. So tensor fold has a very variable anatomy. In most patients, it has a superior concavity. So back again, epitympanic diaphragm, malleus, incus, stapes. So epitympanic diaphragm, which is a transverse structure. So over here, anterior part, anterior to the malleus is a fold, which is a membranous fold, which is a part of the epitympanic diaphragm known as the tensor fold. In 25% of the cases, it is thankfully open, and that's the part when patient would be directly receiving ventilation to the epitympanum via the eustachian tube. In those cases, tympanoplasty, when you're operating, the tensor fold would be closed in 75% of the cases. And in those cases, you will have to open it up. So again, how you open it up during the surgery would be demonstrated over the next three cases, what would be showing today and tomorrow. So again, we have developed a simple instrument which would help you to directly take care of the tensor fold and to open it. I've already talked about the fog and the anterior epitympanic space. I wouldn't go much into details of that. So coming to pro-tympanic space, the pneumatic portion of the middle ear which lies anterior to the mesotympanum and inferiorly to the anterior epitympanic space, is the pro-tympanum. And again, the pro-tympanum, the amount of pneumatization, again, it depends upon how your tensor fold is developed. If your tensor fold is vertical, other than being transverse, again, the pro-tympanum would be larger in size. So simple things which would change the anatomical. Again, depending upon the different types of orientation of the tensor fold, your pro-tympanum, your supratubal recess would be having a varied anatomy, and hence it would have a varied shapes. That is, it can be a rectangular one, a triangular one, or of irregular shape in most of the cases, that is in 45%. And above and medially, like to the eustachian tooth runs the opening of the internal carotid artery, which is again of anatomical importance, because again extensive cholesteatomas, revision cases, the amount of pneumatization, all these things are to be kept into mind when you are doing the cholesteatoma. Hypotympanum, just a simple few lines. It corresponds to the inferior part of the jugular wall, also known as the hypotympanic recess, which is situated below the level of the external auditory canal. And in 70% of the cases, the presence of the jugular bulb, which may be high, which may be dehiscent, the amount of anatomy of the hypotympanum would vary. So ventilation, what I've said, the prostatic space is ventilated posteriorly above and behind to the malleolar fold. Atic ventilation is by the eustachian tube, by the anterior and the posterior isthmus, and directly from here there would be the ventilation of the adytus edentrum and the mastoid posteriorly, and directly mesotympanum would get the ventilation from the eustachian tube. I have two small videos. I'm not running in the operative video, that is when we are doing the tympanoplasty. Okay, I just pause in between whenever I do so. What you can see over here, it's a full-on view of middle ear space which has been opened up. We have given a transcanal incision. The tympanomeatal flap is opened anteriorly. Okay, so what you see, it's a, you can see the lenticular process of the okay. Is it seen? Okay, perfect. So this is an M minus status. It's a very rare situation where you get isolated erosion of the malleus brother. So what is seen is as just stated anterior. You can see the fold over here has been. It's a medial flap. That's not a very big flap. It's a small flap which is elevated. This is the posterior rim of the cavity over here. So these are the various bony ridges what we have seen. So what I have not told previously, little bit to two more terms what I want to mention over here. One is the fustus and one is the funiculus. Funiculus is nothing but a thin bone. During development, when it is formed, it is extending from the inferior part of the round window up to the inferior part of the hypotympanum. So basically, it would separate the hypotympanum from the pro-tympanum. Okay? And can you see this floor of the round window? So this is the round window, and this is the floor. So the floor is formed with a concavity-like structure, not present in all the cases. Very well, it's known as the fustus. So this is the promontory bulb. This is the round window. So this is the into the iris joint over here, incus. This is the cochleariform spaces. So what I was talking continuously, isthmus, isthmus, anterior isthmus. So this is the one. Okay. In between the cochleariform process and the incus. So this space can open. The anterior epitympanic space would be ventilated, and posterior to the incus, then this space is open, that is, it's not covered by glue, that would be taking care of the ventilation of the editus addentrum and the ancus. Okay. So I would start with the reading to the video. So again, the anatomy is seen very beautifully over here. Around window from 1-3 incus. So now the whole of the long process of the incus, the body of the incus, and the short process of the incus is seen. Okay. This is the cochleariform process and the tensor tendon, which is eroded by the disease. It's just been elevated. Nothing is done. It's just elevated. This is the case of N- status with retraction of the epithelium. So whatever was confusing in the initial slide of anatomy, I've tried to simplify over here. So basically, this is the endoscope holder, which is holding the endoscope. So you don't have to hold the endoscope in your one hand and try to do the visualization of the structure. The endoscope is mounted on the endoscope holder, and you have to just drive the endoscope into the middle ear cavity. And once you drive it into it, you can see basically all the stuff. So you don't have to turn the head of the patient. If I just place it, go more inside, I'll be able to see the station view. Okay, over here is the supratubal radius. Can you see it? Over here, it will be the tensor fold, which is open in this case. So what I was saying is a transverse like of fold, which will guide the orientation of the other structures. Now the next is again highly educated video. Now this is another condition in which this is a case of cholesteatoma in which the dissection has been done. You can see some I minus N minus status. That is only the stapes is present. This is the head of the stapes which is seen. This is the anterior thrust. This is the posterior thrust. Okay. This is the round window which is well seen. So basically the endoscope, this is a 0 degree. This is not an angled endoscope. So very much closer view of the round window, what you can see over there. Just take the endoscope very close to the secondary tympanic membrane. So this picture will never get with the microscope. You cannot go so much nearer without losing the details. So this is into the round window niche. The full structure itself. So whenever it comes very much close to the blood, rather than removing the endoscope out, you can just irrigate the cavity so that the parts of the endoscope get clear. And now excluding the concept. Okay, now little bit back orientation. We have focused on the mesotympanum. We have seen the structures, anterior isthmus, posterior isthmus, round window, pro-tympanic space, the supratubal, this is everything. Now little bit going backwards with the same 0 degree. That would be the beautiful picture of the editus addentrum and then. Can you see this pneumatization over here? So I'll just back again, I'll show you how we have done over here. So, okay. So this is the stapes. Okay, now I'm going beyond and upward, posterior and superior to the stapes. Okay, so this is the facial nerve upward. So beyond it would be the etic part and the editus. Can you see this beautiful pneumatization over here? Can you see this healthy mucosa of the antrum? So you may not open and do cortical hysterectomy in each and every case. By just using an endoscope, In every tympanoplasty case, we just open up the anterior isthmus, posterior isthmus takes care of the tensor fold. The ventilation is ensured and hence the success is doubly ensured. So this is a base. You can even see the vessels. This is the picture with the endoscope. So this is the muscle itself which has been with simple 0 degree, not even an angle one, but definitely use an angle one, your visualization will be much more. So muscle itself, healthy itself with no room or granulation. The more you open this, change little bit the direction, you'll be able to see better. So we have taught fellowships in training courses that is in two-handed endoscopic ear surgery. So a little bit details about that over here. And we have an upcoming course in the month of December. That would be the 13th masterclass. 12th masterclass was pre-corona. 13th masterclass would be now in the month of December. Second